Nope. Let's escape. Can I go ahead and get started, Josh?
Yeah, you can go get started.
All right. Hey, everyone. My name's Jack Morgan. I'm one of the PGY2s. Thanks to Dr. Kirshner for helping me put together this presentation, and my going rounds is called Blistering Skin. Here are the required CME slides. I don't have any financial disclosures. Please evaluate. I have the barcode at the end of the presentation. Okay. So chief complaint, total body desquamative rash with mucosal involvement. So HPI, patient is a 28-year-old female currently admitted at OLOL for recurrent multi-drug resistant infections related to chronic skin disease. Patient has a very long hospital course, so I try to summarize it with some bullet points. Patient was started on hydroxychloroquine, metronidazole, and pimecrolimus cream around Thanksgiving of last year by outpatient derm for what they thought was lichen planus refractory to steroids. Several weeks later, the patient presented to the ED with marked worsening of total body rash, skin sloughing of the hands and feet, and mucosal ulceration. Patient was admitted, and skin biopsy taken was suggested of blank disease. She was then transferred to Our Lady of Lourdes burn unit in Lafayette. There, the patient experienced massive skin sloughing. From what I saw in the documentation, it was 99% of total body surface area. She required numerous debridement procedures and tracheostomy for mucosal involvement. Her condition waxed and waned over the next several months. On several different occasions, she was actually stable enough for discharge to rehab, where she was able to reside for several weeks before having to return and be readmitted for septic shock secondary to infection with multi-drug resistant organisms. HPI continued. So Optho has been following this patient since she was first admitted. Initially, she just had these bilateral corneal abrasions that failed to improve completely with various like drops and ointments, so antibiotics, lubricating, and steroid drops. She did get 1 times Procara on the left eye and 2 times Procara and 1 times a soft bandage contact lens in the right eye. By the end of March, before one of her discharge, her corneas were clear without epidefects and the conj appeared mostly normal. At this point, she was only on artificial tears 3 to 4 times a day, and she was on Tobadrex drops, BID. She wasn't seen again until she was readmitted one of these times in May, and now she had like pretty significant corneal scarring in the inferior right eye, and she also had what appeared to be a small corneal ulcer near the inferior limbus of the left eye. Patient was started on fortified antibiotics, zinc and ceftazidime at that time, and they were slowly tapered over the following days as the ulcer improved. She is currently now just on preservative-free artificial tears 6 times a day, and she's on Tobadrex drops BID. Just completing some of her history, her only past history is lichen planus. Her past surgical histories is mainly just comprised of things she had done while she's been in the hospital. So all these different wound debridements, a peg tube, tracheostomy, and then before all this, she had her wisdom teeth out. No past ocular history. She has a father with sleep apnea and insulin-dependent diabetes, and she has a maternal grandmother with SLE. So maybe there's some like autoimmune disease in the family. Social history is non-contributory. We don't know of any drug allergies. Her current medications are everything she's on in the hospital. So it's mainly like vitamins and like skin ointments. So like ascorbic acid, multivitamin, zinc, sulfate. She's on chlorhexidine, Lubriderm, this neomycin, polymyxin, pramoxicin, some topical cream, DVT prophylaxis, ulcer prophylaxis. She's on Tylenol and gabapentin for pain. Then she's on Gamunex C infusion, which is just an IVIG infusion for her illness. And then I've already kind of talked about the drop she's currently on. Okay. So I'll kind of describe this first headshot of the patient. So you can see that she has pretty impressive scarring of the entire face with depigmentation. Really the only areas kind of spared are around the nose and the mouth. She has kind of these crusting lesions kind of all over, and then her lips are pretty severely excoriated with bleeding. I'll give you guys just kind of a moment to look at the eyes. I have some close-up photos in the coming slides. Okay, so these are photos of her right eye. Could I maybe have like a colleague describe some of these for me? Maybe like one of the first.
Sure. So we're looking at external color photo of the right eye in these three photos. In each of the photos, there appears to be crusting superior on the upper lid margin and lower lid margin. I'm not sure what the yellow is, if that's some kind of stain that was applied, maybe with fluorescein, but that's also apparent on both lids. In the second photo, you can see disorganized eyelashes, particularly superiorly, but again, noticing that crusting as well that looks yellowish. And you can also see some conjunctival injection in the eye, maybe about 1+, 2+. I would say potentially some matarosis of the lower eyelid. The farthest right photo looks like, again, external color photo with some fluorescein staining. I do see numerous epithelial defects on the cornea, almost like, trying to describe them. I guess it's not, don't have too great a view of, but looks like some positive and negative staining diffusely across the cornea.
Okay. Yeah, it's pretty good. I guess one thing I would draw everyone's attention to would be looking kind of at that middle external photo. She didn't have her eye completely open, but we had some good lighting on it. You can kind of see there's some vascularization that's kind of extending onto the inferior cornea there. I know it's probably kind of hard to see with the lid in the way. And then that photo on the left, it's also kind of hard to see, but she had kind of corneal haze. We didn't really appreciate corneal epithelial defects, but we're just kind of scarring and haze. So these are photos of the left eye. I'll just kind of describe them for the sake of time. So really they were fairly similar to the other photos. You can see the one with the best lighting's kind of in the middle. You can see there's inferior vascularization and kind of some corneal scarring there. And then there was this kind of weird white plaque going from like 8 o'clock to 9 o'clock. You can see it kind of better in that far left photo. It took up like a lot of fluorescein when we stained it. Going on to complete the exam, so her vision in the right eye was 2400, the vision in the left eye was 2200. The pupil's pressure and the movements were mostly normal. Externally, we kind of already talked about it. She just had all these kind of skin scarring and depigmentation, healing lesions. So for the lids, we said there was crusting and blepharitis, and then we said there was thickening of the eyelids. For the conjugate sclera, yeah, we said there was some injection, but there wasn't any symblepharon and there was no pseudomembrane formation. For the right cornea, we said there was moderate scarring and haze of the cornea extending from the visual axis inferiorly. We didn't appreciate any epi defects. There was no active ulceration, but there was vascularization of the cornea inferiorly. On the left eye, we said there was also inferior scarring on the cornea. We said there was also this white plaque nasally that stains with fluorescein, and there was some vascularization inferiorly again. AC, iris, and lens were mostly normal. So moving on, I guess, to the differential diagnosis. I know she's has like a really like, I guess like a very like systemic disease. So you probably narrowed down your differential, but if people want to also list off maybe some causes of like ocular cicatricial conjunctivitis, I think that'd be helpful.
So SJS or TEN, top.
Erythema multiforme.
OCP for the symblepharon as well, if they've had medications, like medicamentosa as well.
Good. Yeah. Those are some of the ones we had. So yeah, on the top.
I wouldn't say any medicamentosa looks like, that's beyond medicamentosa, I think.
Well, just for the symblepharon for that type of differential.
Yeah. So yeah, I mean, just because you had like all this like pretty like, I guess like full body rash, I mean, you'd kind of eliminate a lot of the things from the differential that would cause just like a cicatricial conjunctivitis, but I think they were just good to go over. But anyway, kind of at the top, like probably want to think toxic epidermal necrolysis or Stevens-Johnson syndrome. Probably next to that is like paraneoplastic pemphigus. If you hadn't had any history and you saw this patient, you may think like they had very like severe like burns, whether it's chemical, thermal. Nothing really in her history would suggest like a graft versus host disease. She does have this history of erosive lichen planus, but typically it doesn't become that severe. Causes of more just like cicatricial conjunctivitis would be kind of listed down here, like mucous membrane pemphigoid or ocular cicatricial pemphigoid. SLE, I saw epidermal lysis bullosa acquisita can cause cicatricial conjunctivitis. Then things like erythema multiforme, atopic keratoconjunctivitis, and infectious conjunctivitis were all listed in the book. Okay. So my objectives today, I want to briefly describe the epidemiology, pathogenesis, and various etiologies associated with SJS-10. I want to review the common systemic and ocular manifestations of SJS-10, including findings of both acute and chronic disease. And then I want to explore the available medical and surgical therapeutic management of SJS-10 and its sequelae. So what is Stevens-Johnson syndrome and toxic epidermal necrolysis? They are diffuse inflammatory vesiculobullous reactions that involve the skin and at least 2 mucous membranes. The nomenclature is going to be based on the amount of skin involved. So SJS is going to be less than 10% of the skin total body surface area involved, while 10 is going to be greater than 30%. There's an overlap syndrome that's kind of in between the two. So if it's 10 to 30%, it'd be SJS-10 overlap. The oropharynx and conj are the most affected mucous membranes. And from what I could find, ocular involvement occurs in 63 to 80% of patients. Epidemiology, so the incidence of SJS is it's greater than 10. So SJS occurs 1.2 to 6 cases per million per patient year versus 10, which is 0.4 to 1.2 cases per million patient years. There is increased incidence with advancing age just because you kind of come into contact with some of the etiologies that can cause SJS-10, but it's not uncommon for like younger patients to develop this. Also, you're at increased risk if you have HIV. I saw there was an association with HLA-B12 and HLA-BW44. And these patients, especially the ones with 10, have pretty high mortalities. You can see down there, it's 25 to 30%, 35% mortality for these patients. Pathogenesis, currently it's thought to be a type 4 hypersensitivity reaction. So the skin cells or keratinocytes undergo apoptosis after being triggered by the cytotoxic T lymphocytes via perforin granzyme pathway or fast ligand interactions. I just dug up this little figure down here from one of my med school textbooks, but essentially if you just kind of focus on everything to the right, it just kind of depicts what this bullet point shows. So the cytotoxic T lymphocyte kind of releases granzyme through this perforin channel, or it can interact with fast ligand to fast receptor. Pretty much does the same thing inside the cell, though. It activates these intercellular proteins that just cause nuclear fragmentation. The cytoskeletal elements kind of break up. The cell dies and forms these apoptotic bodies. The etiologies, so typically we think medications, but there are a lot of infectious causes and then some other kind of weird causes. So just starting off with infectious, the most common would be Mycoplasma pneumoniae and herpes simplex. Our patient got tested for Mycoplasma pneumoniae. They did not have it. Another pretty common culprit is group A strep. And then some less common culprits are adenovirus, Coxsackie virus, Histoplasma capsulatum. Medications, we classically think of our sulfonamides. So our sulfa drugs, oftentimes it's something like Bactrim. Anticonvulsants like phenytoin, NSAIDs, allopurinol, barbiturates, and even occasionally penicillin have been known to cause it. From what I saw, 25 to 50% are considered idiopathic. They never identify a very, like, I guess, a cause. Malignancy, especially like lymphomas in pediatric patients, have been known to cause SJS/10. Radiation therapy, collagen vascular disease. And then I saw associations with the old smallpox vaccine and SJS/10, but I guess we probably don't really see that quite as much anymore. As far as like the systemic signs and symptoms, so the skin findings are typically preceded by several days up to 2 weeks by a prodromal phase. And during this time, they get a bunch of fever. They may have arthralgia, malaise, and then they may get upper and lower respiratory tract inflammations. They'll get things like cough and shortness of breath, and maybe some sore throat. The skin involvement, I have a picture of it on the next slide, but it's classically called a target lesion. And then mucous membranes, when they're involved, it's usually like bullous sloughing lesions. New lesions can pop up anywhere from 4 to 6 weeks after the initial like skin eruption, and they can typically occur in like these 2-week cycles. Long-term non-ocular complications include skin scarring, depigmentation, nail deformity, and vulvovaginal stenosis of the genitalia. Ocular morbidity is very big, though. I'll kind of get to that later. So here are just some photos demonstrating those target lesions. They're supposed to be described as erythematous red, kind of with surrounding white, and then an erythematous base. I don't really see it in some of these bigger ones. I can kind of appreciate it maybe with some of these smaller lesions, but okay. So the ocular manifestations, patients to us are probably going to complain of things like eye pain and eyelid pain and swelling. They'll likely have irritation, redness, and possibly blurred vision. During the acute phase, like that first 2 to 3 weeks, they often have swollen, ulcerated, and crusted lids. They go on to develop mucopurulent conjunctivitis with episcleritis, and they will possibly have conjunctival sloughing, possibly some corneal epithelial defects. Late complications. So these patients can go on to develop very severe, like end-stage ocular surface disease. Some of the things they can develop are eyelid margin keratinization and deformity. They can get really bad trichiasis and entropion. They can also get conjunctival scarring and some bufferon and fornicule shortening. And then most of them develop pretty severe dry eyes due to meibomian gland and goblet cell loss. A really devastating component is limbal stem cell deficiency. These patients will sometimes get really bad corneal scarring, thinning, neovascularization, conjunctivalization, and they may have like really difficult and poor visual acuity, so essentially some corneal blindness. These are just some findings that I was some late findings I was describing in the last slide. This top left external photo, you can see there's some blepharon. I'm not sure if you can see my mouse, but I'm just kind of outlining it over to the left. This top right external photo just shows some pretty impressive corneal vascularization, and the cornea is just kind of overall just kind of hazy. You can't really see through it very well. This bottom left photo is showing corneal conjunctivalization and some vascularization.
And just you could just go back to the prior photo. What the reflex on your upper left photo towards the canthus, do you know why it looks that way? Sort of doesn't look like a normal eye, the area that isn't vascularized?
Say that again. You're talking about the top left photo here?
Top left on the left part of that photo. Why does it have that sheen or lack of sheen?
You're talking about on the conch here where I'm kind of...
Yeah, what is that that looks like that?
Is it keratinized?
Yes, that's what keratinized looks like. Right. Thank you.
All right. So systemic management, obviously if there was like an offending agent, you're going to need to discontinue that. And then mainly you treat these patients with support. They need to be managed in a burn unit, preferably even over an ICU. These patients are going to require pretty aggressive wound care and airway management. And, you know, they're essentially like burn patients. They're going to have really high metabolic demand. So they're going to need enteral nutrition and fluid. Immunosuppression is kind of controversial. A lot of patients will get systemic steroids. I saw prednisone 60 to 80 milligrams a day, possibly for several weeks. I don't think there's a lot of like evidence that suggests it actually helps these patients. And then things like plasmapheresis, systemic cyclosporin, IVIG have all been tried, but I don't think, once again, there's a lot of evidence behind them. Acute ocular treatment. So whether or not there's very much ocular involvement, pretty much all of these patients need aggressive lubrication with either artificial tears or ointments. Most patients are going to need also antibiotic drops and topical steroids. If they begin developing pseudomembranes, those are going to need to be peeled. If they have symblepharon, you can either lyse those early or late. One of the most important things I came across, though, was early use of amniotic membrane. So if they just have corneal involvement, that may just be placing a Procera lens, or if they have like conj and cornea involvement, maybe a amniotic membrane graft. There's a lot of evidence to suggest that this helps prevent some of those long-term like complications associated with SJS. Using them early is important. Here's just a figure I found demonstrating how to place a Procera. So this suggests you anesthetize the eye first, and then while holding up the upper eyelid, you have the patient look down, you place the Procera lens, and then you kind of like pull it, you pull the lower eyelid down to kind of slide it into the inferior fornix. One of the first studies I kind of came across that really promoted the use of amniotic membranes was the study. This was from Journal of Cornea back in 2012. This is a retrospective case series done at Loyola University Burn Center. And essentially what they did is they compared patients with SJS and 10 who only received medical drop therapy versus those who also got drops in amniotic membrane. What they did is they graded the ocular surface disease first as mild, moderate, or severe. And then their outcome that they were looking at was best corrected visual acuity. They said the outcome was good if the best corrected visual acuity was was better than 20/40. It was fair if the best corrected visual acuity was between 20/40 and 2200. And it was poor if the best corrected visual acuity was under 2200, or was worse than 2200, I should say. So one of the biggest problems of the study was that as like a tertiary burn center, a lot of these patients came from out of town. So a lot of them were lost to follow-up just because like likely when they were discharged, they just sought care back in their local communities. So initially they had 182 eyes or 91 patients, but really only 29 patients or 58 eyes had greater than 1 month follow-up. What they found, though, is they graded 23 eyes with moderate to severe at presentation, and those eyes all got like the early amniotic membrane transplant. Of those eyes, only one of them had a poor outcome versus eyes that were medically managed. There were 8 of 23 eyes that had poor outcomes. So 4.3% versus 34.8%, which was significant. A more recent study that was kind of similar was just kind of published in the American Journal of Ophthalmology in 2019. This was a study done by Massachusetts Eye and Ear. It was also a retrospective case series. What they did is they compared patients admitted with SJS and 10 from the year 2000 to 2007 compared to those between the year 2008 to 2017. The key being that in 2008, they implemented a new protocol for all patients with SJS and 10. And the protocol called for early use of amniotic membrane transplantation. So like the other study, their main outcome was best corrected visual acuity, but they also looked at the incidence of some of those late stage complications that I described previously. For the results, so none of the eyes in that first group received amniotic membrane transplantation, as opposed to 87% of the eyes in the second group received amniotic membrane. And what they found was that 92% of patients in the second group had a best corrected visual acuity greater than 20/40, as opposed to the first group, which only 33% of patients had a best corrected visual acuity greater than 20/40. So the patients in the second group were seeing much better. There was also a significant difference in the number of complications in group 1 versus group 2. 67% of patients in group 1 went on to develop those late stage complications, or only 17% developed them in the second group. So here's the protocol that they use at Massachusetts Eye and Ear. Like that first study, they first grade the ocular surface disease. So grade 0, they say, is no ocular involvement. And for those patients, they just start them prophylactically on like lubrication. So they said artificial tears 4 times a day. Grade 1, they said, was just conjunctival hyperemia. There were no like corneal, conj, or eyelid defects. Those patients, they went ahead and started on a topical antibiotic, topical steroid drop and ointment, and they also had them on pretty aggressive artificial tears. Grade 2, they said, was like any corneal, conj, or eyelid margin defect, but without margins or without membranes. For those patients, they also started them on, it was pretty much the same like drop regimen as grade 1, but they would use a Percara lens if only the cornea was involved, and they would use an amniotic membrane graft if there was also like conj and cornea involvement. Grade 3 was essentially the same as grade 2, but now there were membranes. All of those patients got amniotic membranes. So you can see in their protocol, they're using amniotic membranes, like really even if there's like any defect on the eyes. And from what they found in their study, that prevented some of those long-term complications and actually helped protect the patient's best corrected visual acuity. Long-term eye care. So this can be pretty difficult. You know, when the patients go on to develop this end-stage ocular surface disease, they can just be very hard to manage. As far as some of those mechanical abnormalities of the eyelid, these usually require procedural or surgical management. So if they have bad keratinization, they may require mucous membrane grafting. They may require epilation for trichiasis and entropion repair. Most of the patients are going to have dry eyes. Typically, you know, you're going to have to do more than just artificial tears to manage them, because they've had pretty significant loss of their meibomian glands and goblet cells. These patients can have bad corneal thinning and perforation, and in those patients, a penetrating keratoplasty may be necessary. And then kind of lastly, probably the most difficult thing to treat is limbal stem cell deficiency. These patients end up having pretty chronic inflammation and just really bad dry eyes, which makes things like penetrating keratoplasty not very viable. I think they fail pretty often. So keratolimbal allografts and oral mucosal transplantations have been tried. I think those have pretty high failure rates. There have been some success with these permanent keratoprosthesis, these Boston K-Pro type 1 and 2. But once they get to this limbal stem cell deficiency stage, they're just kind of hard to manage. Okay. That's kind of all I had. I don't know if people have questions that I'd be happy to answer.
What was the end
What
result
happened
with the
to your
patient you presented?
Yeah, so we're still following her up. That last physical exam and those photos I took were from the last time I saw her, which was about a week ago. You know, it appears that she has some vascularization and scarring the cornea, maybe from like some limbal stem cell deficiency, because, you know, when we saw her in March, she was looking good. Like the corneas were clear, all the epi defects were gone, and the conj looked really well. So we're just kind of maybe concerned that she's had some of those, the limbal stem cells have maybe kind of been lost. So we're just still kind of watching her. We're trying to decrease her drop regimen as appropriate, just because I think she's kind of frustrated with how long she's been getting all these drops for, and she just feels like some of them burn. So we're just trying to increase our quality of life, I guess.
What's her vision?
It's so right now with near card, it was 2400 and 2200. The first time she was ever seen, her vision was 2020, I think, in 2025. So, you know.
So why is her vision down? Does she have keratitis involving the visual axis? Is there scarring involving the
The
visual
scarring,
axis?
yeah, the scarring is definitely involving the visual axis on the right. She also has very dry eyes,
So have you done punctal occlusion? Is she on Restasis? Does she need a torsorrhaphy? Does she have complete lid closure? I'm just sort of directing at what are some of the things that could improve her vision.
Sure. I mean, I think all those things are good options. I mean, currently she's still obviously admitted.
How long has it been since the injury again?
This all occurred pretty much the last week in November, and she was admitted to the hospital like December 10th or something, or December 11th maybe. So it's been a long time.
She's been in the hospital on and off that whole time?
Yep.
And why is she admitted now? Because this is 6-7 months later. So what's
she's so every time she gets discharged, she ends up having like either skin infections or gets like bacteremia and gets septic shock. So she has to come back in for like treatment either of like wounds or like treatment with like IV antibiotics for these kind of ongoing infections. She's also had some respiratory problems. Like she still has like the tracheostomy, just because she had pretty impressive mucosal involvement with the oropharynx.
Does she close her eyes all the way?
I believe so.
Yeah, because I'd be a little nervous with her in the hospital, and sounds like breathing issues as well, to be on more topical steroids in the eye than she might need. So you want to minimize that as much as you possibly can.
Okay.
This is Dr. Barron. Did you run across in your research any studies comparing putting on Propera, which would cover only the bulbar conjunctiva, as opposed to an amniotic membrane graft that would cover the bulbar conjunctiva, go into the fornices and palpebral conjunctiva?
Yeah, a little bit. So they suggested you do like a amniotic membrane graft if there was like any conjunctival involvement or if there was any like pseudomembrane. I think they really only, from what I saw, like what I was looking up, like you should really only use a Procura if there is like only corneal involvement. Like I think otherwise you should probably be doing a graft.
And just a comment, we had a patient a year or two ago, they presented at Grand Rounds that had Stevens-Johnson syndrome from a topical antibiotic eye drop. I think it was a fluoroquinolone. So it's like, are you kidding me? This happened from an antibiotic eye drop? And the answer was yes. So
Goodness. Okay.
It was from Ocuflox.
did you present that case or?
I saw it and then April presented it because she followed up the patient.
Okay, great, thanks.
Hey, Jack, this is Zach. I was just wondering, how long were they keeping the Procaras in for in the protocols?
I would have to go back and look in there. I'm not totally certain.
Okay, thanks.
Any other questions? All right, I'm going to
Nice
stop.
job.
All right, thank you.
Hello, everyone. My name is Wade Tucker. I'm one of the third years, and my presentation is entitled Not Your Usual Suspect. I want to thank Dr. Blem and Missoula for helping me put this presentation together. All right. These are the accreditation slides. At the beginning of our presentation, I have no financial disclosures to share with anyone today. And please remember to submit your evaluation of my presentation later on after the commencement of grand rounds today. So I'll get right to it. Our patient is a 52-year-old female, was referred to clinic for retinal evaluation after abnormal findings seen on exam by a local optometrist. She stated that she recently started noticing these intermittent blurred vision episodes and a little bit more difficulty reading. And this has been going on for the last 2 to 3 months. She denied any floaters, scotomas, or photopsias in either of her eyes. And she denied using any sort of prescription or over-the-counter drops or medication other than those that we're about to discuss. She does have a history of diabetes, but she says that her blood sugar has been under control for quite some time, and her last A1C was 6.5. So denies any past ocular history, past medical history. She does have hypertension, diabetes, interstitial cystitis, and seasonal allergies. Denies any previous surgeries. No family history of any blinding eye disorders, including glaucoma, macular degeneration, or anything else that she is aware of. As far as her medications go, she is on amlodipine, metformin, Allegra, Elmaron, and denies any over-the-counter drug use, as we previously mentioned. So her basic exam, her vision was 20/30 in her right, pinhole down to 20/25. And in her left, it was 20/40, pinhole down to 20/25 as well. Remainder of the basic exam in that eye was pretty normal. On slit lamp exam, anterior segment was grossly normal, some mild cataracts, but otherwise was pretty normal. So moving on to our fundus exam, we dilate her eyes and we look back to see this. Would one of you guys mind describing what you see here?
Yeah, so this is color fundus photos of the right and left eye respectively. Not sure if the view is hazy or just because of the quality. Optic nerve, looks like it has a healthy neuroretinal rim on both eyes. Let's see. In the macula, it looks like there are these scattered hypopigmented lesions kind of around the fovea and closer to the vessels as well. But it kind of isolates the macula in both eyes. Vessels look pretty healthy to me. Can't really see much in the periphery.
Great, good job, Luke. So exactly just like that. These scattered kind of hypopigmented with lesions with soft borders. They're kind of confluent, maybe some surrounding hyperpigmentation areas or lesions that kind of encompass the foveal and parafoveal regions extending out to the arcades. Perfect. Which is kind of what I mentioned in my dilated fundus exam. Moving on to fundus autofluorescence, maybe somebody would like to explain these as well, but essentially similar findings. So I'll just run through it right quick for the sake of time. Fundus autofluorescent photography, basically showing those similar lesions that we saw on fundus exam. So hypoautofluorescence, these lesions are scattered by areas of hyperautofluorescence, and they're kind of confluent, have non-distinct soft borders, kind of encompass most of the macula and the foveal and parafoveal regions. On to OCT. Can anybody kind of just really briefly describe to me the abnormalities that they might see on these imaging modalities?
Hey, this is Zach. So it looks like there are some like little nodules that are like hyper-reflective at the level of the RPE.
Perfect, Zach. That's exactly what I mentioned. I don't know if y'all see my cursor here, but more so in the top image, temporally, you can see these kind of nodular excrescences in the level of the RPE. distorting the ellipsoid layer just a bit. In the lower picture, kind of more subfovally, you can see one there, more nasally. So yes, exactly. Additional testing that we did on our patient, we did color vision and stereo acuity, both of which were normal. So at this point, having what information we do, what is a differential that some of you guys would have at this point?
AMD.
Great. Anything else?
Other like Stargardt's disease, anything?
Perfect, perfect.
Elmeron.
Lesion.
Okay, so some sort of toxicity, great. Good. So some of the big talking points that I had on my differential at the time kind of separated into atrophic adult onset macular dystrophies, some juvenile causes of macular dystrophies. Obviously, macular degeneration has to be on the differential, and potentially medication toxicity. So some of these, based on our history, can kind of be excluded or put on the very bottom of the list automatically. A lot of these diseases that have autosomal dominant inheritance, as those kind of X'd out in the differential here. So these kind of went down lower on our differential. Pattern dystrophy was certainly there, AMD, and medication toxicity at this point. No real, no obvious players as far as the typical things you would think of as medication toxicity. But as someone alluded to earlier, maybe a new medication the patient's taking that has recent studies that we'll allude to a little bit later that can cause a similar sort of picture. So essentially in this talk, I kind of want to delve into the medication-induced pigmentary maculopathy causes, discuss a little bit about the presentation and findings of Elmeron toxicity, and then kind of describe the study that first showed the strength of association with this maculopathy and Elmeron toxicity. So as far as I mentioned earlier, some of the more commonly associated medications that can produce a sort of retinal toxicity, such as the one we see in our patient. The chloroquine derivatives certainly can do this, which I'll allude to here in a second, and are kind of a hot topic at the moment with the current coronavirus treatment. Phenothiazines, an antipsychotic class of medications, can also cause a pigmentary maculopathy, not so similar to the picture that we see here. More so, early fundus changes will show kind of this circumscribed nummular areas of RPE loss that can extend from the posterior poles to the mid-periphery. The exact mechanism of this toxicity is not really known at this point, but the thought is maybe it has to do with some disruption in the rhodopsin synthesis and leading to secondary loss of the RPE and choriocapillaris. Some of the below medications are also seen, but in less frequency. And as far as the pentosand polysulfate sodium, aka Elmeron, we'll delve a little bit into further on in the talk. So just like I mentioned earlier, just a refresher on chloroquine toxicity, since it's kind of being brought up quite frequently these days. So how would you start seeing some signs and symptoms of this in your patient? They may have things like a paracentral scotoma, anything from decreased visual acuity, metamorphopsias, photophobias, any abnormalities that they can potentially have can be elucidated to this. They're very vague and nonspecific. Various mechanisms that have been proposed to date that may be causing some of these symptoms and the toxicity include some things like retinal recycling inhibition, disruption of the lysosomal function associated with this process, and essentially primary retinal toxicity. A little refresher on the major risk factors: daily dosage, anything greater than 5 mg per kg of the patient's real weight of hydroxychloroquine, and of the chloroquine, essentially the anti-malarial drug, anything greater than 2.3 mg per kg of the patient's real weight. Also, duration of use is a big factor as far as toxicity goes. You know, this table straight from the AAO mentions greater than 5 years have increased risk of the patient developing toxicity. Other things that can increase a patient's risk in taking this drug are renal disease, mainly due to the decreased glomerular filtration rate, in which the drug just kind of lasts in the system a little longer. Concomitant drug use, especially tamoxifen for breast cancer and pre-existing macular disease. And just a refresher on some of the screening guidelines. They recommend per AAO, the new guidelines that were put out in 2016 recommend a baseline fundus exam to rule out any pre-existing maculopathy. And then the frequency of exams afterwards are kind of determined based if there is present pathology or not. After 5 years on the drug, this patient should be brought back and beginning annual screening. Annual screening uses perimetry with automated visual fields and OCT. Typically, we see the 5-line rasters in our clinics. And then something also to remember in the white versus Asian patients, you need to get a slightly extended perimetry in these Asian patients because they can have extramacular pattern of damage. So maybe consider a visual field of 24-2 as opposed to the 10-2s that most of the Caucasian patients receive. Some ancillary testing that can help in the screening process are ERGs. Fundus autofluorescence can also give you a little bit more information, but more so ancillary testing as opposed to the primary recommendations. The goal is to find toxicity before you see it on exam, mainly because this retinopathy is not reversible and there is presently no therapy to treat or reverse the damage that has been done by one of these chloroquine derivatives. So a little bit further on to our drug, Elmeron. So what is it? What is it used for? And why are we suddenly talking about it now and seeing signs of it? So interstitial cystitis is what Elmeron is used to treat. This is essentially a regional pain syndrome that affects about 1 million individuals in the United States, more prevalent in females. And it manifests as bladder or pelvic pain, and it can lead to incontinence and dysmenorrhea. Elmeron, aka pentosan polysulfate sodium, it works as binding to the urothelium in the GU tract, and it provides somewhat of a protective layer that helps prevent painful urination, which is one of the most common symptoms of interstitial cystitis. The reason PPS has been such a good drug and heavily used drug is that it's the only FDA-approved oral medicine for interstitial cystitis that was approved, round about 25 years ago in '96, and patients have thought to be tolerating this drug really well without any really known side effects up to this point in time. Common dose that patients are started on is 100 milligrams 3 times daily. So what may you see in a patient who presents with this form of toxicity? They can have anything from blurred vision, difficulty reading, metamorphopsia, some paracentral scotomas, maybe difficulty with dark adaptation. And then on exam, upon dilated exam, you may see some of these parafoveal pigmented deposits like we saw earlier in our patient, possibly vitelliform deposits or these patchy paracentral RPE atrophy areas. And they can definitely look similar to beginning signs of AMD. They can mimic pattern dystrophies as well, which is, I think, initially why some of these may have gone undiagnosed or incorrectly alluded to one of these other diseases. So similar to chloroquine screening guidelines, two of the big tests that have been used so far are OCTs, which we showed earlier, in which some of these nodular RPE excrescences have been noted at the RPE level. Perimetry kind of varies widely, and possibly having some decreased foveal thresholds, maybe some paracentral scotomas, ranging from anything from that to being completely normal. Fundus autofluorescence is also heavily used, as we saw a little bit earlier, and it highlights a lot of the things that you see on exam, these kind of confluent lesions at the level of the RPE. Near-infrared reflectance imaging and ERG are also other modalities that can help in the process of kind of discerning early stages of this toxicity as well. So what are the risk factors? I'm going to go over the study here in a second that first kind of picked out how this all started and how it was kind of alluded to medication toxicity associated with this medicine in particular. The current thought is that the risk of toxicity with Elmiron is mainly seen in those patients who have been on the drug greater than 10 to 15 years. There's also thought to be a dosage component to it. However, there's multiple ongoing studies to try and see if there is a certain threshold that increases the patient's risk of developing a toxicity. So further studies on that are kind of ongoing at this point in time. So there's no consensus or official recommendation for guideline screening. However, as we mentioned above, some studies have come out to say that they recommend baseline exam and imaging with OCTs, fundus autofluorescence, and annual follow-ups after your base exam, regardless of pre-existing status. And it is also unclear at this time, much like other medications, if stopping the offending agent will even stop future retinal toxicity or loss in vision. Okay, so on to our study. This was actually a study presented at AAO last year, and it was a study presented by Dr. Jain. He is a retina specialist and retinal pathologist at Emory University, who a few years back began noticing a string of patients coming in with what he thought at the time to be pattern dystrophies. However, did some chromosomal testing and nothing really ever popped up. So having said this, he tried to delve a little bit further and look at what else could be causing some of these pigmentary maculopathies, whether it be medication, whether it be some other disease process that some of these other patients had in common. The one thing that a lot of his patients had in common was A, the diagnosis of interstitial cystitis, and B, this use of this Elmiron drug. So he went back and did a diagnosis search and also a pharmacy search on those patients that were diagnosed with interstititis and also on PPS, and subcategorized them into two groups. One arm being the IC patients not on Elmiron, the other arm being the patients that have taken Elmiron. In the non-Elmiron use group, there were 0 confirmed cases of pigmentary maculopathies, while in the PPS group, there were 14 confirmed cases of the PPS maculopathy group. All these cases were confirmed similar to the mechanisms that we mentioned earlier, both with OCTs, bilateral pathology in nature. These paracentral macular hyperpigmented spots are also seen on fundus autofluorescence. And they kind of use the same process to work up some of these patients, as we mentioned earlier. The mean age of the patients in this study were 61, and most of which, 89% of which, were females. They found that it was the only statistically significant predictor of this unspecified pigmentary maculopathy of any other variable that they included in the study, and with an odds ratio of 11.25. So this kind of set in motion the further research of trying to quantify, trying to find some sort of way to measure retinal toxicity based on dosage, based on any changes they find, and relate it to the dose, the quantity, the amount of time taken. And that's a lot of those studies are currently ongoing. So if there were no other reason to know about Elmiron toxicity, one big reason is that the lawyers have caught on to this study and they have started a class action lawsuit. So my feeling is that this won't be the last time you hear of Elmiron toxicity, and patients will start to learn about this as well and ask your opinion on things if they have any sort of vision changes or retinal findings. So finally, back to our patient. She's currently undergoing genetic testing, and those results are pending. Her ERG is scheduled, and we'll follow up with those results the discussion was had once all these findings came back with the PCP and her urologist, and they discussed with the patient to stop Elmiron and switch to a different agent to treat her illness. These are my references. Does anyone have any questions?
Very nice presentation.
Thank you, Dr. Weiss.
So for now, would you follow these folks the way you would follow with hydroxychloroquine or chloroquine?
I think
If
there's a
someone
lot.
comes in on this and they're asymptomatic, how do you follow them?
Exactly, and I think that's the biggest thing. And if they are asymptomatic, I would assume at the very least an annual exam, and I'd probably do something similar to along the lines of hydroxychloroquine. Although I think my best guess is that it probably is a big factor of how long they've been on the medicine, and you know, a lot of times you don't see any sort of changes until they've been on the medicine for 10 to 15 years. So I would, if it were me, I'd probably follow them with an OCT, perimetry, and an ERG if available. Has anybody encountered this sort of toxicity in their clinics, or can anybody shed light on any patients that they've seen with this?
Well, I guess if there are no questions, do you all, or are you residents doing their own questions then?
Yes, Dr. Weiss, we are.
Yes.
Okay, well, good